Good morning. My name is Stefan Wolf. I'm from Switzerland, from the University Hospital in Zurich, and I come from a whole different approach. I spent the last years in drug development and identifying new pathways and find also drugs for these pathways. And about 3.5 years ago, I switched to the University Hospital of Zurich and focused on lymphedema and lipedema research. Today, I want to compare it to a third disease, lipohypertrophy, and we started to do the first basic science studies and compare these three entities directly together. I have nothing to disclose, and I want to start right away. What is the problem? The problem between these three diseases is that we have a diagnostic bias. They all three have a similar phenotype, and we have the problem of patient expectations, that we have a quick and correct diagnosis, but on the other hand, we have the problem that we're lacking standardized and objective histological and molecular determinants. And what makes it even more difficult is that all three of them are progressive diseases and changing all the time. I have to admit it was not our idea to compare these three conditions. It doesn't matter which lipedema guideline you are looking at, the German, the UK, the Dutch, or the US guideline, you always find this table in these guidelines. And these three diseases are always compared to each other because of their similar phenotype. Over the last years, a lot of research was done in secondary lymphedema, and also lipedema is getting more and more research done. But in lipohypertrophy, nothing is published at all. We went through the databases, and there were no papers about it. The only thing where you find it is in these guidelines. And I don't want to bother you with the whole table, but I just want to point out the differences. For example, edema is one difference where you see quite clearly in secondary lymphedema. In lipedema, we have to discuss about it in what stages, but it's completely absent in lipohypertrophy. Then we have the inclusion of the feet in secondary lymphedema, and then we have the pain. For us, pain was a clear diagnostic criteria. It has to be present in lipedema. If it was not present in lipedema, we categorize it as lipohypertrophy. All the other diagnostic criteria between lipohypertrophy and lipedema are overlapping, so what was differentiating them was the pain for us. And we were lucky enough that we have a lot of patients in our hospital, and we're able to get a lot of samples which we could analyze. From lipohypertrophy, there were a little bit less, and that's why it takes until last year when we were able to make a small study cohort where we were able to analyze 10 patients per group, where we tried to match them in age, but also in BMI to reduce the variability of our studies. The lipedema patients with stage 2 included were 6, and stage 3, 4. And in lymphedema, we had 7 stage 2 patients and 3 stage 3 patients. I don't know how familiar you are with these pictures. These are pictures from the skin. I get the skin sample, and they were really thinly sliced, and then you can stain them with different colors depending on what you want to see. In the upper row, you see in dark purple, that's the epidermis. And it's a hallmark of lymphedema and lipedema that the epidermis is increased. This hallmark is completely missing in lipohypertrophy. And I'm also not sure how much you know about statistics. As soon as in one of my diagrams there's a star above it, I'm happy because then the difference between the two groups are significant. In the lower group, you can see this red staining. That's a staining for fibrosis. And there we see significantly less fibrosis in the skin in the lipohypertrophy. We did the same for the adipose tissue, for the fat tissue. And at first, we looked at the adipocyte size and could see across all three conditions an increase of the adipocyte size. But when we stained it also for fibrosis, for the collagen, we see that the fibrosis is mainly present in lymphedema. In lipedema, we see a strong tendency towards it, but our study cohort was too small to see that. But what was striking that especially lipohypertrophy did not show any signs of fibrosis. Now we are coming to another topic which is quite discussed. That is the edema part. And there you can also stain the skin samples for markers for the lymphatic vessels. And from the total coverage, we see a significant difference in the lipohypertrophy. And that was quite striking, that we have way less lymphatic vessels in it, in the total coverage. But if you want to judge more about the presence of an edema, you have to look at different markers. And for example, these are growth factors which are present in the fat tissue. And we see that the VEGF-D growth factor is responsible for vascular permeability. And this is reduced across all three conditions. But we were not 100% satisfied that lymphedema does not stick out particularly, because there the edema is clearly present. And then we looked for lymphatic tight junction genes, which is, for example, claudin-5 or connexin 43. And there we could show that lymphedema has a quite unique gene expression, especially for the lymphatic function. A topic which was discussed quite a lot today was the infiltration of immune cells. And what we see that especially in lymphedema and in lipedema, there are more immune cells in the tissue. This also differentiated quite clearly from the lipohypertrophy. And if you if you look a little bit more detailed, we could show that, or that's published data, we could show that CD4 cells is a marker for lymphedema, in contrast, and it's not present in the lipohypertrophy. Sorry, no, I was too fast. Which is quite unique for the lymphedema, and there's also, that's the work of the last 5 years, that macrophages are a marker for lipedema, and there we see that a common macrophage marker is quite specifically upregulated in the lipedema tissue, and especially our group focused on a more detailed analysis of this macrophage compartment. And there we see that there are two types of macrophages, M1 and M2. M1 macrophages are more present for inflammation, while the M2 macrophages are more important for anti-inflammatory, promotes tissue growth and wound healing. And we see these M2 macrophages quite significantly upregulated in all our lipedema patients. What makes it even more interesting is that it has a quite specific marker, the CD163. We think that it's a potential biomarker in the future. We get, at the beginning of this year, we got quite a lot of samples, in total 80 samples from Germany, and could analyze in a stage-specific way that these M2 macrophages are already present in the first stage of lipedema, which would mean we would have a biomarker even in the first stage, which could show that could provide maybe an earlier diagnosis. Currently, we are working to analyze serum samples because this CD163 is also in a soluble form present in the blood, and we hope to maybe find a blood marker. What's new? This is the table from the beginning, but we were able to extend it and show quite clearly that lipedema and lipohypertrophy, apart from their similarities, have on molecular and histological basis quite some differences. It's in the epidermal thickness, in the lymphatic system, and also that the fibrosis is in lipohypertrophy completely missing. Furthermore, we see that in lymphedema we have the CD4 cells, which play a crucial role, while in the lipedema, the macrophages. All these immune cells are missing in the lipohypertrophy, where also the pain is missing. What we further plan is that we now focus on the earliest possible stages of lipedema to analyze them, to get to see if our macrophage marker is maybe significantly present there. Expand our population, because now it's a really small cohort. We have to expand to other countries to get more samples. And the Lipedema Foundation granted also the award that we are now investigating these biomarkers. And the last slide is to say thank you to my PI, Epakosopoulos, and Julia von Atzingen, which is my doctoral student, and our collaborators from Finland and Germany. And of course, the people who pay our bills, mainly the Lipedema Foundation, and the Sosella Foundation and the Novartis Foundation for the lymphedema part of the study. And at last but not least, I want to thank you for your attention.